Hello, and a very warm welcome to all our attendees to today's ICTD Connect meeting. I'm Marianne, and I'm speaking from the International Society for Neglected Tropical Diseases, and I've seen many familiar names among the attendees, so welcome back to you all. And if you're new to ICTD Connect, well, this is our series of meetings launched during the COVID lockdown to keep the scientific community connected and engaged. So an extra warm welcome to you if you're new to our group. So today is the 3rd of December, and the world has been marking the UN International Day of People with Disability. This day is hugely important, of course, in its own right, but really carries additional weight specifically for the neglected tropical disease community. As we know, not only do NTDs affect some of the world's most vulnerable, but most of these diseases will impose further and substantial burdens, not only on individual patients, but also families and, in fact, entire communities. And by this, I mean, of course, disability, but also stigma, exclusion, and all that derives from it. So thankfully, the international community, whether at a grassroots level or at a high level, has really been coming together to accelerate not only the control and management of the diseases, but also to reduce the barriers themselves that are faced by those affected by the diseases. And crucial frameworks such as the recently launched WHO NTD Roadmap to 2030, in fact, specifically emphasize this. But how do you go from these policy frameworks to what's actually happening in communities? And how can we best harmonize in a real sense disease management on the one hand and disability inclusion? Well, to answer these questions on this very special day, I'm delighted to welcome today's speakers. And in the spirit of celebrating a World Day, we have actually quite a large group tuning in from many different parts of the world. So today, to speak to us about disease management, disability and inclusion, and why disability inclusion is critical to achieving NTD Roadmap targets, I would like you all to join me in welcoming our speakers today. It's my really absolute pleasure to welcome 5 panelists who have worked in many different aspects in this field for many, many years, some in fact for decades. Although I'm sure many of you don't actually need an introduction, I will still try my best to welcome all 5 of you. So Dr. Wim van Brakel, you're joining us today. You are chair of the NNN's Disease Management, Disability and Inclusion Working Group, and you're also a medical director at NLR. Hello, Wim.
Hello.
Hi. Dr. Martin Kollmann, you are a Senior Advisor for Neglected Tropical Diseases at CBM International. Hello, Martin. We have also Dr. Nand Lal Banstola, Deputy Director at NLR Nepal.
Hello.
Hi. And Mrs. Mangala Dhondge, Deputy Program Manager at the Leprosy Mission Trust, India. Hi, Mangala.
Hi.
And it's wonderful to have you because we've had a lot of connection problems. So touch wood, everything's going to be absolutely fine. And Professor Hannah Kuper joining us from the London School of Hygiene and Tropical Medicine and Director of the International Centre for Evidence in Disability. So hi and welcome, and thank you so much for joining us today. So without any further ado, I'm going to hand it over to Dr. Wim van Brakel. Wim, you will be taking us through most of the issues that we're trying to cover today, and we'll be hearing from our speakers from a lot of different perspectives and angles, interventions, all the way from the policy side of things to what's been happening in communities. And with that, I hand over to you, Wim, and thank you so much to all our attendees for joining us and for our speakers as well. Thank you.
Thank you, Mariana, for this introduction. So let's share a few slides with you related, and I'm hoping to give just a quick overview of some of the topics that are important in relation to this question. And let's move to the main targets that are now specified in the new WHO NTD Roadmap 2021-2030. There are 4 so-called overarching targets, and I would like to focus especially on the first 2, which is a 90% reduction of people requiring interventions against NTDs and a 75% reduction of fewer NTD-related DALYs, disability-adjusted life years. And the reason for highlighting these 2 is that they both relate to disability, because while in the field of NTD, prevention of NTDs and also elimination of these diseases has been high on the agenda and continues to be extremely important, there is a shift in the roadmap to a more person-centered approach, and much more attention for the consequences that many people who live with NTDs face on a daily basis. And so they are the people often who require interventions against NTDs, not just in the form of 1 or a few doses of preventive chemotherapy, but they may require services even lifelong. And then the reason that NTDs are such a global burden is partly because of the large numbers that are affected, partly because of the mortality that some of the NTDs cause, but also especially because NTDs tend to be disabling diseases, and that is the focus of our of this day and also of our topic today. Disability management, disability and inclusion has been a term that we have coined to describe a holistic approach for providing person-centered services in the NTD field, and promoting policy and strategies and interventions in a number of different areas. And the first is to manage disease complications in order to prevent disabilities from happening, to prevent and self-manage disabilities, which is particularly the area that tends to be called MMDP, morbidity management and disability prevention. Also to promote mental health and well-being, to reduce NTD-related stigma, improve inclusion and the participation of persons affected, which is extremely relevant to this day and also will be highlighted further in contributions from other panelists, and to promote human rights as a rationale for providing services in the NTD field. So, just a few examples here of what that might mean: reducing NTD-related disability and promoting inclusion. That is done by preventing new disabilities due to NTDs. So detection and treatment of complications, teaching of self-care, but also formation of self-care groups and self-help organizations plays a main role in this. And then there is the inclusion of people with NTD-related disabilities in rehabilitation, in more mainstream programs and services, helping people to optimize their activities and their social participations, for example, through physical rehabilitation, things like assistive devices and surgery, but also importantly, and with growing attention for that globally, attention for mental health of persons affected. Then there's the hugely important area of socioeconomic rehabilitation and what used to be called CBR, because many people that are affected by NTDs also suffer from poverty. Then to train people in human rights and how to use these, to support equal opportunities for those affected. And as I mentioned, promoting participation of persons affected in NTD programs. This has also been an area that is in development and that has recently become much more into focus in the entire NTD world. And lastly, the integration of persons with NTD-related disabilities in other DPOs. In many countries, there are disabled people's organizations, and persons with NTD should also be facilitated and encouraged to join those. Secondly, and lastly, the inclusion of people with other disabilities in NTD programs and activities. For example, ensuring equal opportunities in joining self-help groups or organizations, but also ensuring accessibility of NTD services, for example, in education materials such as Braille or in sign language, in providing sign language, attention for physical accessibility of buildings that are involved in NTD services, inclusion of persons with disabilities in NTD campaigns, and using accessible ITC materials. And so that is what I wanted to share by way of introduction into this topic. If you're interested in joining the NNN DMDI cross-cutting group, then here is an email address that you can write to. Thank you very much, and back over to you, Marianne.
Thank you very much, Wim, and I think that collaborative message has been heard loud and clear. So for anybody who wants to find out more or in fact collaborate in a very practical sense, then by all means definitely reach out to Wim and the cross-cutting NNN group, and we'll put some contact details up as well very shortly. Now I'd like to move on to our next speaker, Dr. Martin Kollmann.
Thanks so much, Marianne. I want to build on what Wim just presented with a focus on trachoma and inclusive eye health. Next, please. So the WHO World Report on Vision highlights the magnitude of visual impairment and blindness and calls for integrated and people-centered approaches. On the other end, the WHO new NTD Roadmap highlights the magnitude of NTDs as diseases of poverty and marginalization, and it is characterized by a paradigm shift towards integrated, cross-cutting, and, importantly, inclusive approaches. So trachoma sits somewhere in both sides as an eye disease, and the WHO report from the weekly epidemiological report from July 2020 indicates the great success of ending trachoma by using the SAFE strategy that has been achieved. Next, please. So trachoma is a disease of poverty and equity, as said, and it's a leading cause of vision-related disability. It's estimated that 1.9 million people experience visual impairment or blindness. And as a disabling NTD, it is an important issue for both the NTD and the eye health community. So children typically get infected and have the highest burden of infection, and adults suffer from the consequences of visual impairment and blindness. And the impact of this trachoma-related disability is clear. Many of them in their middle ages are bread earners. They suffer from stigma and mental well-being issues. Women are particularly affected. They're twice as likely to require surgery than men, and children often become the caregivers because their parents are visually impaired or blinded by trachoma. Next, please. So here we clearly see on the upper left side the slope leading gradually to blindness. And on the right lower sketch, you see the various areas of intervention, the surgery, the antibiotics, the clean faces, and the environmental improvement. So what is often missing here is, what do we do for those already living with visual impairment and blindness? And the answer definitely has to be integrate and link between eye health, inclusive eye health, and rehabilitation services. And maybe just to mention that there has been published a new WHO estimate on rehabilitation needs, which might also be of interest. So it's clear we do have a comprehensive public health approach with a SAFE strategy, but the question of what to do with those already living with visual impairment is often not as well developed in trachoma programs. Next, please. So as demonstrated earlier, trachoma links NTDs with eye care, And there are several areas where we need and indeed can address disability. So when we look at the vision-related disability, we have the SAFE strategy for the prevention and the medical interventions. But then, as Wim already pointed out, we have to address other aspects like mobility training, like Braille and sign language, and importantly also livelihood, which I think is really a very important cross-cutting aspect. When we look at hearing, we have to look at the messaging, for example, around behavior change campaigns that are so important for the facial cleanliness and environmental improvement, or the camp announcements that come along with the MDA, the Mass Drug Administration activities. Or when we look at physical impairments, how do we ensure that there's access to infrastructure, for example, at the WASH infrastructure or hospitals for surgery? And when we look at education, how do we utilize school clubs for trachoma, eye health and general public health, also at the same time, for example, for stigma reduction? And how do we ensure that children who, as I pointed out earlier, often are at home as caregivers, then that they are actually going to school? And what's often missing, really, as Wim also pointed out, is the aspect of stigma and mental health and mental well-being, which really needs to be embedded in all our trachoma work. Next, please. So what are NGO groups such as the ICTC, the International Coalition for Trachoma Control, or the DMDI cross-cutting group, what are they currently doing to mainstream disability inclusion and participation as part of human rights-based approaches? So the ICTC, for example, is very strong on collaboration and on advocacy, and also will address these aspects with a new focus in their new strategic framework that's currently under development. So you see on the right side many very good examples of advocacy documentations, blogs, and so on. And I just a particular thank you to Tim and to our partner at the moment from the ICTs who have really facilitated and helped in developing those. And then on the DMDI cross-cutting group, we have the collaboration with very strong input in the new WHO NTD Roadmap and intense collaboration with other NNN groups, be they other cross-cutting groups like the WASH group or disease-specific groups like the Trachoma group or the Leprosy group or the LF group. And importantly also, the NNN, the DMDI cross-cutting group facilitated and helped the NNN to bring about this statement, adopt this statement on participation of people affected by NTDs at the recent NNN conference. Next, please. So what's really today at the World's Disability Day is required is that we have a call to action. The lack of good disability data across NTDs and eye health communities is hampering really our efforts to achieve our elimination goals and to truly leave no one behind. So on the left side, I think good data is something that we need, and we need to address this in the future, how to better embed those in our general NTD programs. And what you see on the right side is that I also think there is an urgent need to engage beyond our traditional constituencies with social sciences, that we look and investigate the impact of disability on the accessibility and acceptability of all trachoma interventions. And when I talk about trachoma here, that actually extends to other NTDs too. That we look at the impact of trachoma on disability-related stigma and mental well-being, to research on the inclusive preferred practices, which is very important, and the trachoma community has been very strong in developing such preferred practice, but that needs to look at aspects or strengthen aspects of inclusive components, and also how to promote the intersectorial working that promotes the formation and inclusion of organizations of persons with disabilities. And all that must be done to enable us to promote human rights-based, participatory and people-centered approaches. And without all this, we will not be able to end the neglect from NTDs, and we will not be able to leave no one behind. Thanks.
Thank you very much, Martin. This is hugely important, not just to discuss in principle what needs to be done, but having these very concrete and clear calls to action, really very useful, very important, and definitely we will watch this space to fill in those critical gaps. I would like to welcome the next speaker, Dr. Nand Lal Banstola, tuning in from Nepal.
Hello.
Hello. And there's been a beautiful bird in the background of our webinar. So I don't know in which country this bird is singing from, but...
So good afternoon and good morning, everybody. I'm Nand Lal Banstola from Nepal, and I'm working with NLR. Today, in this very short time, I will speak on hidden facts that majorities of us knowingly or unknowingly ignore, but this matters on the life of individuals. This is about disability, disease, and inclusion. So, inclusion itself is a common terminology, but its explanation differs each per practitioners. I have here in my slide displayed what we are usually using in our long experiences of community dynamics and model programs. This inclusion itself is different from integration, and this is not only for the disability. As we believe, disability is used because disability friendly means more friendly to all remaining other categories of the peoples. And we also believe that it is not only them, but we are also diverse. Now here, I'm going to present the 3 case studies. The first case study is about one male with disability, and the case study second is a female with disability due to disease, and it is due to NTD, leprosy. And case study 3 is a female with disability, disease, and she is from the Dalit category, one of the untouchable category in context of Nepal. And here in this case study 1, if we compare because of the impairment, it is comparatively more severe than the case study 2 and 3. But interestingly, due to associated stigma and disease, the disease might be NTD or other, life of case studies 2 and case studies 3 are more complicated. Whereas case study 3 is one of the challenging humanitarian or human rights issues. Even due to charity or welfare, thinking of the communities on this appearance, on his appearance, case study 1 was almost successful. So that difference is because of the associated stigma with these all 3 case studies. Yeah, these 3 case studies, they started their journey, their life journey, almost together or at the same time, and they have the same socioeconomic background and the same geography, but we can see even there were quite lot of barriers. Case study 1 remained almost successful for his life journey. Case study 2 is still struggling for survival. Even marriage life is not that much successful, but case study 3, she is passed away at the young stage and could not complete her life journey. This, I'm here talking about the realities or the facts representing from the conditions of either developing or underdeveloped countries. These are not the stories. Hence, for the future, considering we as a global family and keeping SDGs or Sustainable Development Goals the tools for making global changes, I would like to recommend to elaborate more on leave no one behind. I would like to recommend the 3 inclusion strategies to be added on this, so that our dream of a pretty world beyond 2001 that will become a reality. Finally, I would like to conclude with my remarks that we human beings are all different, but more similar than different. Thank you. Thank you, Marin. Marin, it is over to you.
Well, thank you very, very much, Nand Lal. This is really a fantastic example of going into the communities, how to apply all these approaches that we've been discussing. And Mangala also, with examples coming from India, would also like to share something on a similar note.
Hi, I'm Mangala Dhondge, working with the Leprosy Mission Trust India, and I'm heading one project called Jagruti. The project is inclusion of persons with disability through sustainable livelihood in Maharashtra, India. We are focusing on sustainable livelihood models, unemployed to entrepreneur, and ladder of livelihood. Slide number 3. These are the goals and objectives of the project. This is the project working area. We are working in one state of Maharashtra and Amravati district, and we are working with 58 villages. We develop a ladder of livelihood. The project is included in a single slide. We started the working with people with disability from the identification of person with disability. We did their survey. We developed the individual development plan with them. We did the livelihood assessment of a person with disability. We provided them thematic skill training. We develop business plan for them. We do the exposure visit for them. We develop the demonstration center where the other people can go and learn from this project. We link the people with disability with the governments and other NGO schemes. And finally, we link them with the livelihood. And this is the result of inclusion and participation of persons with disability. This is the basket of livelihood we developed in this project. We find out how many livelihood opportunity in the villages, and there are 23 to 35 livelihood opportunity in the village where a person can stay within his village and do the livelihood at their own village. Slide number 7. This is the case study of Mr. Rajyo Dhurve. He is a person who is having the locomotor disability, and he was dropped out from the school because of his locomotor disability, because he is from the very rural area of Maharashtra village, and there is no opportunity for going to school. Then he was doing nothing, and he was just hopeless and helpless with his life. During this Jagruti project, we find out that he wanted to do something with his life, and we developed the demonstration center with him. Now he is a resource person of goat farming demonstration center. People go to learn to him. He explained the people what is the goat farming business, and he is earning 10,000 to 15,000 from this business, and he also shared the success of this business. Slide number 8. This is the business plan, goat farming business plan we developed through Jagruti project, and we develop the business plan from 5 goat, from 10 goat, from 20 goat, how many income and expenditure these are. And we find that if a person start goat farming with the 20 goats, from after 2 years he can earn 8,36,000 approx from after 2 years of his work. Slide number 9. This is the livelihood demonstration center we developed in Jagriti project. These are the 6 demonstrations. These are various like grocery shop, then poultry farming, fishery, goat farming, like this. And these are the demonstration center where other community also go and learn and how to develop their business successfully. So this is the idea of this demonstration center. Slide number 10. These are the thematical skill training we provided with person with disability. After thematical skill training, we provide them 90 days, 60 days thematical training. These are divided in 2 parts, in practical and theory. And after their 90 days training, they become a master of this business and they do their business with skill. And slide number 11, this is our Jagriti team. Thank you very much.
Brilliant, and thank you, Mangala. If you can hear us at least, then thank you so much for this presentation and this incredible work on all fronts to really make disability inclusion a complete part and building block of not just public health, but also overall community development and engagement. So thank you so much for that very concrete example, an inspirational example. And finally, I'll now hand over to Hannah. Professor Kuper, thanks for joining us, and over to you.
Thanks for having me. So my name's Hannah and I'm at the London School of Hygiene, and I'm going to be presenting on the global agenda. So Vim set the framework for the NNIs and the kind of action needed for disability inclusion, and then Martin gave a very nice description of inclusive health for trachoma, and then Nadler and Mangala gave country-specific examples, and I feel like I'm zooming all the way out again to see how this all fits in the global agenda. So as everybody on the call knows, NTDs and disability are strongly linked, that people with disabilities are more likely to get NTDs and that many of the NTDs are disabling. And in fact, that's one of the reasons why we care so much about NTDs, is because of the disability that they cause, whether we're talking about leprosy or onchocerciasis or trachoma or lymphatic filariasis. They can be strongly disabling. And so the implications of this is twofold. So on the one hand, as Mangala and Nadler showed, we need to think about rehabilitation for people who have NTDs. And on the other side, as Martin said, we need to think about inclusion of people with disabilities in our programs, like within trachoma elimination. And I'm going to show a little bit about how that fits into the kind of global debates that are going on at the moment. So if we think about linking people, so there are people who have NTDs and they have become disabled as a result, they've developed impairments. The one thing that people may need or benefit from is rehabilitation and assistive technology. And the global gaps in rehabilitation and assistive technology are very well understood now. So in terms of rehabilitation, there's a huge lack of human resources. So on a global level, there are fewer than 10 human resources people working on rehabilitation per million people in low middle income countries. And as a result of population growth and the rise in NTDs and NCDs, today 1 in 3 people could benefit from rehabilitation. So there's enormous need set across against few human resources. So as a result of this, there's been various international actions. So the one is the WHO's Rehabilitation 2030 program, which was launched 2 years ago. And it's trying to fill in these gaps by improving rehabilitation management and investment, by building a high quality rehabilitation workforce and services across the world, and by focusing on more data collection on rehabilitation to try and stimulate more investment in rehabilitation sector. People living with NTDs may benefit from assistive devices, so whether it's to help people walk, people with visual, who may have visual impairments, to be able to mobilize independently or to carry out other activities of daily living. And access to assistive devices can really be extremely liberating and life-changing. But unfortunately, in low middle income countries, assistive devices only cover 5 to 15% of the need. So there's an enormous need for assistive devices among people living with NTDs or other conditions, which at the moment isn't being met. And so there's an impetus for NTD programs to link for assistive devices, but also more generally. And there's some global actions here. So the WHO has launched the Global Cooperation on Assistive Technology. That's the GATE program. And the GATE program is trying to improve access to assistive devices through increased provision, better and locally produced products, and improved access of personnel who know about assistive devices. And then a parallel program that's going on at the moment is called At Scale, which is through the Global Partnership of Assistive Technologies. And its vision is to try and provide 500 million people with assistive devices by the year 2030 by some of the actions that are being done through GATE, so kind of scaling up the availability, the provision, but also making sure that what is being offered is suitable and locally produced. But as both Nadler and Mangala talked about, rehabilitation is broader than that. And so this is the WHO's CBR matrix, which is community-based rehabilitation, which is basically saying, yes, medicine is important and healthcare is important and assistive devices and rehabilitation is important, but that the needs of people with disabilities, whether due to NTDs or other things, is broader. So people may benefit from vocational training if they need to change their jobs. There can be social support, self-help groups, empowerment, advocacy groups, disabled people organizations. And I think this is a picture from Lepra, who, as Mangala showed, is investing in CBR. So this is a kind of a global movement to think more comprehensively about rehabilitation beyond medical assistance, rehabilitation, and assistive technology. So one of the impetuses is to link NTD programs to rehabilitation, assistive devices, and CBR more generally. And then the question is, why is this not happening? And from my perspective, I mean, one issue obviously is lack of resources, but the aim of the NTD programs is often about elimination or eradication, so that these diseases will disappear and therefore there won't be disability resulting from them. But at the moment, in today's world, there are millions of people living with NTDs, and the programs are not going to achieve elimination or eradication immediately. So I think there's still a very important need to consider these wider ramifications for people living with NTDs. And then the other side is inclusive health, so to make sure that our NTD programs are inclusive of people with disabilities. And again, here, this sits well against the global agenda. So, and to show that this is a very important issue. So for instance, in COVID, which obviously we're talking about a lot today, in the UK population, actually in just England and Wales population, 16% of people are living with disabilities. But people living with disabilities contribute to 59% of COVID deaths. So this is just to show that people with disabilities on average have far greater healthcare needs and are often excluded from healthcare services and interventions, and therefore experience worse outcomes as they do with COVID. So we need to think more about inclusive health. And there are some actions happening here. So the WHO obviously is thinking about disability inclusive health. It's one of their priorities. And their toolkit has recently came out, I think yesterday, for the Western Pacific region. I've been working on the Missing Billion initiative about access to healthcare for people with disabilities. And then obviously it's also human rights, on the human rights agenda. So the UN Convention on the Rights of Persons with Disabilities reiterates the rights of people with disabilities, both to accessing health and rehabilitation. So this isn't a luxury, but this is something that's very fundamental that health programs must do. So one of the things that NTD programs must be thinking about is how to be disability inclusive. And why is this not happening? Well, within the missing billion, we've thought about lots of different reasons, and there are different areas that we need to tackle. So we need to tackle awareness and data. So it's fantastic that these kinds of seminars are being hosted, and we're collecting more data globally, not least through the Washington Group questions, which are here on the slide. There needs to be more planning and more resource allocation, so that we need to invest in inclusion and accessibility right from the start. There needs to be partnership with people with disabilities, and this goes with the disability community of nothing about us without us slogan, to make sure that what is being developed, which programs are developed, are accessible and appropriate for people with disabilities. And there needs to be leadership and governance to say these programs must be disability inclusive, and there have been gaps here too. And just to reiterate again that trying to strive through inclusion of people with disabilities and provision of rehabilitation, as the NTD programs are doing, is important, and that these are also fundamental human rights. But there's also evidence that if we think about inclusion and we think about holistic programs, we will make better programs that are better for everybody, to meet diversity in all its forms, whether it's due to disability, ethnicity, gender, age, and so on. Thank you very much for your time and attention, and for celebrating International Day of Persons with Disabilities with this seminar.
Thank you very much, Anna, for your perspective. We actually first met a few years ago when Zika was in all the headlines in 2015, and just in the same way that perhaps approaching disability through the lens of one specific disease, then disability again came up to the forefront of international discussions and, you know, in terms of engaging the public, but also policymakers, governments, and so forth. So thank you very much for putting all this on the radar once again. We've had, of course, a lot of food for thought from our fantastic speakers and questions coming up in the chat. And so I would like to, at this point, hand over to Wim to answer any questions, but also to prompt a discussion. Wim, you've worked tirelessly, really, in this field for many decades in all aspects of leprosy control and disability integration, and also geographically with your work in India, working in Nepal. I'd like to hand over to you to bring together all these issues that we've heard about today and perhaps answer some of the questions coming up from our attendees.
Yeah, thank you, Marianne. I think we should quickly move to questions that have come up in the chat. The first question that came up was to Martin, and that is relates to the WHO endorsed SAFE strategy for trachoma that has been critical in reducing trachoma by 91%, no less, since 2002. However, with its focus on surgery, antibiotics, facial cleanliness, and environmental improvements, how can we ensure that other components to surgery, such as rehabilitation, are not forgotten? Martin.
Thank you. And let me just highlight that this comprehensive public health strategy, the SAFE strategy, has been indeed dramatically successful, as the question points out, a reduction since 2002 by 91% of people at risk. And also now 10 countries have been able to be certified to eliminate trachoma as a public health problem, and also distributed over all the different continents, so working in different contexts. So that's very important. But I think we have two aspects here to make it truly comprehensive and make it inclusive. The one aspect is that we have to ensure the access of persons with disability, whether this is caused by trachoma or by other conditions. And I think one of the key elements there is really what the new roadmap is emphasizing, and what also the World Report on Vision is emphasizing, is people-centered approaches and integration of various platforms, such like eye health, inclusive eye health, and trachoma, and also the mainstreaming into the general health system and beyond, because we work beyond health when we talk about WASH, for example, there, and link, for example, with the social departments for social health too. And the other aspect is that, as Hannah has pointed out, that we really need to closely work together with rehabilitation. And you can see already when WHO talks about rehabilitation, it's typically the medical rehabilitation. What about the psychosocial aspects of that, including mental health? So working together, these cross-cutting approaches, I think, are really crucial to make this very successful SAFE strategy fit to eliminate trachoma and to also contribute to the Leave No One Behind agenda of the SDGs to make this a reality.
Thank you very much, Martin. And Nand Lal, there's also a question to you. You've emphasized the importance of human rights in the context of disability inclusion. And if you think of an NTD program, and you are working in a leprosy program, although in an integrated fashion, but can you give a practical example of how a human rights approach was used in your situation, in the context of the leprosy control program?
Yeah, especially after the introduction of UNCRPD, the health part or NTD and the human rights, these things are more highlighted. So in some of the countries where health is basic issue of human rights, in those countries, the NTD Roadmap is developed, and in the NTD Roadmaps, the strategy is clearly mentioned, and it is against discrimination and the legal policy provision services for the people. So if human rights perspective are positive, NTD will get more benefit that is clearly shown in those countries.
And I believe in the not so distant past, you've also stood up against the introduction of discriminatory legislation. Can you very briefly tell something about that?
Yeah, that was about the marriage, including the leprosy affected and persons with disabilities. For example, in Nepal also, in the constitution, they were ready to put that issue, part of that issue. We were able to remove or reduce, but it is not completely removed, even due to the networking or lobbying we did during that period. It became so strong, and publics are not ready to accept that. So it makes a difference for the life of the people.
Yeah, I think that shows how it's important to work at different levels. So the legislation level, which may be at the national high level, as well as in the community. And maybe to you, Hannah, you've also stressed the importance of human rights in the context of disability inclusion. Can you maybe elaborate on one or two of the main barriers that you see that need to be overcome to ensure human rights approaches in the programs?
I think awareness is the biggest issue. So I think often people they want to do the right thing, but this is not something that people have necessarily considered. So to think, oh, I hadn't thought about there being so many people with disabilities who need these services, or oh, I hadn't thought about the need to refer people on. I've been thinking about prevention of this disease in a narrow way. So I think that's the first barrier to overcome. And as far as I can see with the NTDs, it's been a little bit variable. So I know, for instance, there's been lots of work around leprosy about more comprehensive rehabilitation, which maybe I haven't seen as much with other NTDs, but perhaps it's happening. So I think awareness is one. And then I think the second is planning. And so working with people with disabilities to plan from the start. But maybe some of the practitioners, so Martin or Nanda, would also be able to give input there.
Thank you. Yeah, it's Martin, please.
Yeah, if I may, and I fully agree, Hannah, but I think also we can't under stress the importance of the evidence, of good data. What I've tried to put into my presentation, what came clearly out from yours, I think good data to create the evidence will inform this lack of awareness. And that will help us also to address this need for funding in our discussion with funders, where many people have been, let's say, eager or quite keen to fund specific elimination programs, but forget about these inclusive components. And the key thing among that is also to change this all, I think, is really the participation of persons affected, and understand and recognize the expertise they bring to the table. They know why certain things don't work on the ground and why programs are not inclusive and what to do to make them inclusive. So once we focus and mainstream really participation throughout all our programs, whether these are Trachoma programs or other NTD programs or other related like iHealth, public health programs, then I think we have a realistic chance to move in the right direction.
Thank you, Martin. And yes, indeed, I think all the speakers this afternoon have mentioned the importance of nothing about is without us, and hence the participation of persons affected. Maybe Nand Lal, you can give us an example of how that was done in the program you worked in.
Yeah, please, Dr. Wim, can you repeat your question, please?
A practical example of how you involve persons affected by NTDs, persons affected by leprosy, in the program.
Yeah, we, starting from the planning or designing of the interventions to implementation level, we always use the persons affected. We are working with leprosy and sometimes with their other entities too, but our core business is leprosy. So I will give you the leprosy example. Starting from the planning to the implementation, we always use the persons affected. That benefits for both, not only for persons affected, but also for the program. Persons affected because it changes their reputation or recognition with the policy influencing people. That is why they are established as a contributor rather than recipient. So it reduces the stigma. Similarly, in the program, why they are so much concerned about this type of the things, that is taken very seriously. So it makes difference for the program also. For your previous question, I can give you one more example about the human rights and NTDs. For example, let us take the case of leprosy. Every country in the world nowadays, they are eager to eliminate or eradicate leprosy. Why? Because the social consequences associated with leprosy and the human rights issues, they were contrite, and people or policy level people came to understand that this is the issue, we need to finish this for the overall development of the society. So that are the reasons it makes the difference. Yeah.
Okay, thank you very much for those examples. I realize, Mariana, that we're at 3 o'clock. Do you want to continue for a bit, or what's your advice?
Well, personally, I'm enjoying this very much. I'm more than happy to stay much longer. Of course, at the same time, I know we have come up to the end of our allocated time. Perhaps the speakers need to go, but certainly from our side, no rush at all to cut discussions short. So feel free to take a few more questions if if you're all available.
Anna, are you still okay? Yeah. We had just to take a question that has come up from Aparna Adams, which is quite a technical question. So I don't know if you can read with us in the chat also. What recommendations does the panel have for NTD stakeholders to further advocate for disability inclusion across health and development issues? Thinking specifically about conversations that can help to prioritize policy and programmatic action with funders, national or regional programs, and where those conversations could take place. Now, that is a question to be dissected, but if anyone volunteers to have a go at that, then please, the floor is yours. Martin.
Yeah, I think that's a crucially important question. And I think one of the key aspects is to recognize that national governments at the moment, to align with the SDGs, are defining their universal healthcare packages. And that's done by national governments. There's guidance from WHO and other UN organizations, but it's national governments who define this. So to engage, use the World Report on Vision and use the NTD Roadmap and get into a conversation with governments that these aspects are addressed when they design their universal healthcare coverage packages. I think that would be a key entry point in my view.
Hannah, do you have a contribution to that? Oh, you're muted, Hannah.
We've been looking at different programs to look at the level of disability inclusion, and it is really important to have those conversations and to get people with disabilities mentioned. But I think then it needs, the further it goes, the more likely it is to happen. So to make sure that people with disabilities are specifically included, mentioned in policies and programs, then perhaps to define what they mean by people with disabilities and what specific actions are going to be taken to assure inclusion, and that they are then funded, and that there's also ultimately monitoring and accountability to make sure that that happens. And so there's a kind of a progression of different things that you want to build upon, from that first mention to concrete plans and so on. And the deeper you can go and get that embedded in policy and programmatic actions, what we found is the more likely that you will then have inclusion.
Thank you.
Wim, if I may just add to this, like you had this the MNE framework developed by the WHO NTD department for the NTD Roadmap. Well, there wasn't any talk in that about disaggregating data for disability. So if you don't measure it, don't put it in the meal framework, as Hannah said, you know, then it won't happen and there's no accountability. So it's very crucial that we work at all levels, that actually this is addressed, that it is measured, and that we hold ourselves accountable. And we can't do that if it's not included through use of disaggregated data.
And then to link this back, so the issue of advocacy and lobby for disability inclusion at higher levels to the previous topic of involving persons affected, I think that is also a key strategy. We should not only involve people at, say, more grassroots activities, but where possible, also at national level. And I know that that is happening in Nepal through general disabled people's organizations, Nand Lal. Can you describe how that is actually done? And are people with NTD-related disability involved in that also?
Yeah, here I would like to mention 2 points. Number one, the most important thing is the data. That's why the government can understand how much is the weight of the problem. The second thing is, even within the disability, there are the diversities. And some part of the disabilities are really problematic due to associated stigma with this. Majority of those if they are due to disease, any type of the disease, for example, we can take the example of leprosy or filariasis, they are more, there is more stigma on those type of the disabilities. So in Nepal, at the beginning, it was very difficult to integrate the persons affected by leprosy or filariasis into disability mainstreaming. But gradually, when people are oriented, when they started to understand, the final conclusion is the disability. Whatever may be the reason, the final conclusion is the disability, and those group of the people are more vulnerable. When it is understood, the integration, real integration is started, and nowadays the situation is different.
Right.
So, yeah, the main thing, these are the main things. Yeah.
And you're working with a national association of people with disability, right? And
yes.
Are they involved in this sort of high-level advocacy also?
Yeah. They have the great value in Nepal.
Hannah, the issue of data has been mentioned several times, and we know that so the term Washington Group questions that are nowadays used quite widely. How would you say in this particular context that they could be applied, and are they relevant to NTDs at all? Yes or no?
So I've seen, I think it's Sightsavers has done some interesting work where they've used the Washington Group questions on people who are coming to seek care for trachoma, so that they can compare the people coming for, I think it was antibiotics or mass discrimination, to the general population to see whether there seemed to be a general bias, so that these programs were missing people with disabilities. I think that would be helpful. But for looking at things like what the rehabilitation needs are with people with impairments from NTDs, I don't think that the Washington Group questions will be enough. So there might need to be a bit more deeper dive into the kinds of difficulties that people are experiencing and what might be helpful there. So I think maybe to set a kind of a vision of what the inclusive holistic programs would look like and what evidence is needed to try and what evidence gaps are stopping that from being achieved at the moment, and to try and fill those in.
Yes, from our own experience, we have sort of moved in recent years to measuring things that are, as it were, close to people's to what people experience as important needs, such as social participation, which would include work participation, and the stigma experience, and most recently also different aspects of mental well-being. And we advocate that those be used also in NTD programs because they highlight very tangible issues that are directly relevant to people's lives. If something can be improved, for example, in the mental health area, very often there are no services at the level where people with NTDs are at. And so we need to think and work with the health system to try and improve that. And there's been some interesting work done on involving either lay counselors or people with personal experience of NTDs as counselors or as mental motivators, peer supporters. Different terms are being used for that. And I think that that work is very encouraging. And we tend to see that if people are involved themselves in helping others, and that also provides a very powerful means for empowerment and for helping people to strengthen their own resilience. I wonder if we need to work towards a wrap up, Marianne. We have one question in still unanswered in the chat, which is about the cold chain facilities. But I don't know if any of the panel would like to attempt at answering that. What efforts are being made to make the cold chain facilities earlier used for polio, measles, etc., available for COVID-19 vaccines in poor countries of the world, especially the regions covered by the NTD researchers and donors. I don't know an answer to that, but I don't know if any of you know that. So if not, then
that would depend on which vaccine is, for example, to be distributed, because some of them don't need just a cold chain, but a very cold chain. So you know, I assume that governments will work on integrating and utilizing those various vaccines for COVID and restarting or continuing other vaccination programs. But yeah,
right.
Nothing else.
Yeah,
and
no. Sorry, sound is breaking up.
Not to worry, because we are planning a supply chain ICTD Connect coming up in the next few weeks. So perhaps we can hang on to those thoughts for that time. Okay,
excellent. Well, I think I would like from my side to thank the other panelists warmly, and also Mangala, who unfortunately wasn't able to stay with us for the discussion, but we're also very grateful for her contribution. And I would like to hand it back to Marianne. To you, please.
Thank you so much, Wim, and I'd like to echo those thanks, really from all of the attendees, from all of us here at ICTD as well. Massive thank you, and also not just for today's participation, but just for the huge amount of work that is going on across your many regions and approaches. And we've talked a lot about mostly leprosy, we've mentioned trachoma as well, but all these lessons and all these processes and advocacy that you've been putting in place will be hugely beneficial to patients in all sorts of diseases, within tropical diseases, whether it be Baroli ulcer, lymphatic filariasis, and many more. All these neglected patients are really going to draw immense benefit, we hope, and governments also pledging a lot more resources to all sorts of disabilities, including mental health. And thank you for pushing that agenda forward, and also for showing us how to work in this very cross-cutting and inclusive way, all the way round, and all the way from the disease management, disability and inclusion group at the NNN, but also in the field, in country, how you're engaging communities. So that's been a really very inspirational talk on so many levels. So lots of attendees are joining me in saying thank you. Hilary Addy is saying here, thank you all for enlightening us, and that's absolutely right. So from us here at ICTD, it's goodbye for now. Definitely many conversations to be continued. I'd also like to say a little thank you here to Tim Jasudasen from the ICTC, who's been posting a lot of really useful resources throughout the session. So if there's anything you'd like to review, please don't hesitate to go to the chat and click through or download those reports as well as links. Finally, this session has been recorded, so if you would like to review anything that's been mentioned, that will be available on our YouTube channel. And for now, from us at ICTD, it's goodbye for the time being. I hope everybody keeps safe. Thank you for your time, and I look forward to seeing you all very soon again. Thank you to the speakers.
Bye-bye, Marianne. Thank you very much.
Thanks very much.
Bye-bye.
Bye, everybody.